Welcome to the Dr. Izzy's Medical Podcast channel.
Diabetes mellitus, commonly known as just diabetes, is a group of metabolic disorders characterized by a high blood sugar level over a prolonged period of time. Symptoms often include frequent urination, increased thirst, and increased appetite. If left untreated, diabetes can cause many health complications. Acute complications can include diabetic ketoacidosis, hyperosmolar hyperglycemic state, or death. Serious long-term complications include cardiovascular disease, stroke, chronic kidney disease, foot ulcers, damage to the nerves, damage to the eyes, and cognitive impairment. Diabetes is due to either the pancreas not producing enough insulin, or the cells of the body not responding properly to the insulin produced. There are three main types of diabetes mellitus. Type 1 diabetes results from failure of the pancreas to produce enough insulin due to loss of beta cells. This form was previously referred to as insulin-dependent diabetes mellitus or juvenile diabetes. The loss of beta cells is caused by an autoimmune response. The cause of this autoimmune response is unknown. Type 2 diabetes begins with insulin resistance, a condition in which cells fail to respond to insulin properly. As the disease progresses, a lack of insulin may also develop. This form was previously referred to as non-insulin dependent diabetes mellitus or adult-onset diabetes. The most common cause is a combination of excessive body weight and insufficient exercise. Gestational diabetes is the third main form, and occurs when pregnant women without a previous history of diabetes develop high blood sugar levels. Type 1 diabetes must be managed with insulin injections. Prevention and treatment of type 2 diabetes involves maintaining a healthy diet, regular physical exercise, a normal body weight, and avoiding use of tobacco. Type 2 diabetes may be treated with medications such as insulin sensitizers with or without insulin. Control of blood pressure and maintaining proper foot and eye care are important for people with the disease. Insulin and some oral medications can cause low blood sugar. Weight loss surgery in those with obesity is sometimes an effective measure in those with type 2 diabetes. Gestational diabetes usually resolves after the birth of the baby. Signs and symptoms. The classic symptoms of untreated diabetes are unintended weight loss, polyuria, increased urination, polydipsia, increased thirst, and polyphagia, increased hunger. Symptoms may develop in weeks or months in type 1 diabetes, while they usually develop much more slowly and may be subtle or absent in type 2 diabetes. Several other signs and symptoms can mark the onset of diabetes, although they are not specific to the disease. In addition to the known symptoms listed above, they include blurred vision, headache, fatigue, slow healing of cuts, and itchy skin. Prolonged high blood glucose can cause glucose absorption in the lens of the eye, which leads to changes in its shape, resulting in vision changes. Long-term vision loss can also be caused by diabetic retinopathy. A number of skin rashes that can occur in diabetes are collectively known as diabetic dermatomes. Diabetic emergencies. People with diabetes may also experience diabetic ketoacidosis, a metabolic disturbance characterized by nausea, vomiting and abdominal pain, the smell of acetone on the breath, deep breathing known as Kussmaul breathing, and in severe cases a decreased level of consciousness. DKA requires emergency treatment in hospital. A rarer but more dangerous condition is hyperosmolar hyperglycemic state, which is more common in type 2 diabetes and is mainly the result of dehydration caused by high blood sugars. Treatment-related low blood sugar, another name, hypoglycemia, is common in people with type 1 and also type 2 diabetes depending on the medication being used. Most cases are mild and are not considered medical emergencies. Effects can range from feelings of unease, sweating, trembling, and increased appetite in mild cases to more serious effects such as confusion, changes in behavior such as aggressiveness, seizures, unconsciousness, and rarely permanent brain damage or death in severe cases. Rapid breathing, sweating, and cold, pale skin are characteristic of low blood sugar but not definitive. Mild to moderate cases are self-treated by eating or drinking something high in rapidly absorbed carbohydrates. Severe cases can lead to unconsciousness and must be treated with intravenous glucose or injections with glucagon. Complications of diabetes. All forms of diabetes increase the risk of long-term complications. These typically develop after many years, around 10 to 20, but may be the first symptom in those who have otherwise not received a diagnosis before that time. The major long-term complications relate to damage to blood vessels. Diabetes doubles the risk of cardiovascular disease, and about 75% of deaths in people with diabetes are due to coronary artery disease. Other macrovascular diseases include stroke and peripheral artery disease. The primary complications of diabetes due to damage in small blood vessels include damage to the eyes, kidneys, and nerves. Damage to the eyes, known as diabetic retinopathy, is caused by damage to the blood vessels in the retina of the eye, and can result in gradual vision loss and eventual blindness. Diabetes also increases the risk of having glaucoma, cataracts, and other eye problems. It is recommended that people with diabetes visit an eye doctor once a year. Damage to the kidneys, known as diabetic nephropathy, can lead to tissue scarring, urine protein loss, and eventually chronic kidney disease, sometimes requiring dialysis or kidney transplantation. Damage to the nerves of the body, known as diabetic neuropathy, is the most common complication of diabetes. The symptoms can include numbness, tingling, pain, and altered pain sensation, which can lead to damage to the skin. Diabetes-related foot problems may occur and can be difficult to treat, occasionally requiring amputation. Additionally, proximal diabetic neuropathy causes painful muscle atrophy and weakness. There is a link between cognitive deficit and diabetes. Compared to those without diabetes, those with the disease have a 1.2 to 1.5-fold greater rate of decline in cognitive function. Having diabetes, especially when on insulin, increases the risk of falls in older people. Causes in diabetes mellitus. Diabetes mellitus is classified into 6 categories: type 1 diabetes, type 2 diabetes, hybrid forms of diabetes, hyperglycemia first detected during pregnancy, unclassified diabetes, and other specific types. The hybrid forms of diabetes contain slowly evolving, immune-mediated diabetes of adults and ketosis-prone type 2 diabetes. The hyperglycemia first detected during pregnancy contains gestational diabetes mellitus and diabetes mellitus in pregnancy. The other specific types are a collection of a few dozen individual causes. Diabetes is a more variable disease than once thought, and people may have combinations of forms. The term diabetes, without qualification, refers to diabetes mellitus. Type 1 diabetes mellitus explanation. Type 1 diabetes is characterized by loss of the insulin-producing beta cells of the pancreatic islets, leading to insulin deficiency. This type can be further classified as immune-mediated or idiopathic. The majority of type 1 diabetes is of an immune-mediated nature, in which a T-cell-mediated autoimmune attack leads to the loss of beta cells and thus insulin. It causes approximately 10% of diabetes mellitus cases in North America and Europe. Most affected people are otherwise healthy and of a healthy weight when onset occurs. Sensitivity and responsiveness to insulin are usually normal, especially in the early stages. Although it has been called juvenile diabetes due to the frequent onset in children, the majority of individuals living with type 1 diabetes are now adults. Brittle diabetes, also known as unstable diabetes or labile diabetes, is a term that was traditionally used to describe the dramatic and recurrent swings in glucose levels, often occurring for no apparent reason in insulin-dependent diabetes. This term, however, has no biologic basis and should not be used. Still, type 1 diabetes can be accompanied by irregular and unpredictable high blood sugar levels and the potential for diabetic ketoacidosis or serious low blood sugar levels. Other complications include an impaired counter-regulatory response to low blood sugar, infection. These phenomena are believed to occur no more frequently than in 1% to 2% of persons with type 1 diabetes. Autoimmune attack in type 1 diabetes. Type 1 diabetes is partly inherited, with multiple genes, including certain HLA genotypes, known to influence the risk of diabetes. In genetically susceptible people, the onset of diabetes can be triggered by one or more environmental factors, such as a viral infection or diet. Several viruses have been implicated, but to date there is no stringent evidence to support this hypothesis in humans. Among dietary factors, data suggest that gliadin may play a role in the development of type 1 diabetes, but the mechanism is not fully understood. Type 1 diabetes can occur at any age, and a significant proportion is diagnosed during adulthood. Latent autoimmune diabetes of adults is the diagnostic term applied when type 1 diabetes develops in adults. It has a slower onset than the same condition in children. Given this difference, some use the unofficial term type 1.5 diabetes for this condition. Adults with latent autoimmune diabetes of adults are frequently initially misdiagnosed as having type 2 diabetes, based on age rather than a cause. Type 2 diabetes is characterized by insulin resistance, which may be combined with relatively reduced insulin secretion. The defective responsiveness of body tissues to insulin is believed to involve the insulin receptor. However, the specific defects are not known. Diabetes mellitus cases due to a known defect are classified separately. Type 2 diabetes is the most common type of diabetes mellitus. Many people with type 2 diabetes have evidence of prediabetes before meeting the criteria for type 2 diabetes. The progression of prediabetes to overt type 2 diabetes can be slowed or reversed by lifestyle changes or medications that improve insulin sensitivity or reduce the liver's glucose production. Type 2 diabetes is primarily due to lifestyle factors and genetics. A number of lifestyle factors are known to be important to the development of type 2 diabetes, including obesity, lack of physical activity, poor diet, stress, and urbanization. Dietary factors such as sugar-sweetened drinks are associated with an increased risk. The type of fats in the diet is also important, with saturated fat and trans fats increasing the risk and polyunsaturated and monounsaturated fat decreasing the risk. Eating white rice excessively may increase the risk of diabetes, especially in Chinese and Japanese people. Lack of physical activity may increase the risk of diabetes in some people. Adverse childhood experiences, including abuse, neglect, and household difficulties, increase the likelihood of type 2 diabetes later in life by 32%, with neglect having the strongest effect. Gestational diabetes. Gestational diabetes resembles type 2 diabetes in several respects, involving a combination of relatively inadequate insulin secretion and responsiveness. It occurs in about 2 to 10% of all pregnancies and may improve or disappear after delivery. It is recommended that all pregnant women get tested starting around 24 to 28 weeks gestation. It is most often diagnosed in the second or third trimester because of the increase in insulin antagonist hormone levels that occurs at this time. However, after pregnancy, approximately 5 to 10% of women with gestational diabetes are found to have another form of diabetes, most commonly type 2. Gestational diabetes is fully treatable, but requires careful medical supervision throughout the pregnancy. Management may include dietary changes, blood glucose monitoring, and in some cases, insulin may be required. Though it may be transient, untreated gestational diabetes can damage the health of the fetus or mother. Risks to the baby include macrosomia, congenital heart and central nervous system abnormalities, and skeletal muscle malformations. Increased levels of insulin in a fetus's blood may inhibit fetal surfactant production and cause infant respiratory distress syndrome. A high blood bilirubin level may result from red blood cell destruction. In severe cases, perinatal death may occur, most commonly as a result of poor placental perfusion due to vascular impairment. Labor induction may be indicated with decreased placental function. A cesarean section may be performed if there is marked fetal distress or an increased risk of injury associated with macrosomia, such as shoulder dystocia. Diabetes mellitus is diagnosed with a test for the glucose content in the blood, and is diagnosed by demonstrating any one of the following. Fasting plasma glucose level greater than or equal to 126 mg per deciliter. For this test, blood is taken after a period of fasting, in the morning before breakfast, after the patient had sufficient time to fast overnight. Plasma glucose greater than or equal to 200 mg per deciliter 2 hours after a 75-gram oral glucose load is in a glucose tolerance test. Symptoms of high blood sugar and plasma glucose greater than or equal to 200 mg per deciliter either while fasting or not fasting. Glycated hemoglobin greater than or equal to 48 millimoles per mole. Or greater than or equal to 6.5 diabetes control and complications trial %. A positive result, in the absence of unequivocal high blood sugar, should be confirmed by a repeat of any of the above methods on a different day. It is preferable to measure a fasting glucose level because of the ease of measurement and the considerable time commitment of formal glucose tolerance testing, which takes 2 hours to complete and offers no prognostic advantage over the fasting test. According to the current definition, 2 fasting glucose measurements above 126 mg per deciliter is considered diagnostic for diabetes mellitus. Prevention for diabetes mellitus. There is no known preventive measure for type 1 diabetes. Type 2 diabetes, which accounts for 85 to 90% of all cases worldwide, can often be prevented or delayed by maintaining a normal body weight, engaging in physical activity, and eating a healthy diet. Higher levels of physical activity reduce the risk of diabetes by 28%. Dietary changes known to be effective in helping to prevent diabetes include maintaining a diet rich in whole grains and fiber, and choosing good fats, such as the polyunsaturated fats found in nuts, vegetable oils, and fish. Limiting sugary beverages and eating less red meat and other sources of saturated fat can also help prevent diabetes. Tobacco smoking is also associated with an increased risk of diabetes and its complications, so smoking cessation can be an important preventive measure as well. Diabetes management. Diabetes management concentrates on keeping blood sugar levels as close to normal, without causing low blood sugar. This can usually be accomplished with dietary changes, exercise, weight loss, and use of appropriate medications, insulin, oral medications. Learning about the disease and actively participating in the treatment is important, since complications are far less common and less severe in people who have well-managed blood sugar levels. Per the American College of Physicians, the goal of treatment is an HbA1c level of 7 to 8%. Attention is also paid to other health problems that may accelerate the negative effects of diabetes. These include smoking, high blood pressure, metabolic syndrome, obesity, and lack of regular exercise. Specialized footwear is widely used to reduce the risk of ulcers in at-risk diabetic feet, although evidence for the efficacy of this remains equivocal. The relationship between type 2 diabetes and the main modifiable risk factors like excess weight, unhealthy diet, physical inactivity, and tobacco using are similar in all regions of the world. There is growing evidence that the underlying determinants of diabetes are a reflection of the major forces driving social, economic, and cultural change, globalization, urbanization, population aging, and the general health policy environment. Diet in diabetes. People with diabetes can benefit from education about the disease and treatment, dietary changes, and exercise, with the goal of keeping both short-term and long-term blood glucose levels within acceptable bounds. In addition, given the associated higher risks of cardiovascular disease, lifestyle modifications are recommended to control blood pressure. Weight loss can prevent progression from prediabetes to diabetes type 2, decrease the risk of cardiovascular disease, or result in a partial remission in people with diabetes. No single dietary pattern is best for all people with diabetes. Healthy dietary patterns, such as the Mediterranean diet, low-carbohydrate diet, or DASH diet, are often recommended, although evidence does not support one over the others. According to the ADA, reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence for improving glycemia, and for individuals with type 2 diabetes who cannot meet the glycemic targets or where reducing anti-glycemic medications is a priority, low or very low carbohydrate diets are a viable approach. For overweight people with type 2 diabetes, any diet that achieves weight loss is effective. Medications in diabetes. For glucose control. Most medications used to treat diabetes act by lowering blood sugar levels through different mechanisms. There is broad consensus that when people with diabetes maintain tight glucose control, keeping the glucose levels in their blood within normal ranges, they experience fewer complications, such as kidney problems or eye problems. There is, however, debate as to whether this is appropriate and cost-effective for people later in life in whom the risk of hypoglycemia may be more significant. There are a number of different classes of anti-diabetic medications. Type 1 diabetes requires treatment with insulin, ideally using a basal bolus regimen that most closely matches normal insulin release, long-acting insulin for the basal rate and short-acting insulin with meals. Type 2 diabetes is generally taken with medication that is taken by mouth, although some eventually require injectable treatment with insulin or GLP-1 agonists. Metformin is generally recommended as a first-line treatment for type 2 diabetes, as there is good evidence that it decreases mortality. It works by decreasing the liver's production of glucose. Several other groups of drugs, mostly given by mouth, may also decrease blood sugar in type 2 diabetes. These include agents that increase insulin release, agents that decrease absorption of sugar from the intestines, agents that inhibit the enzyme dipeptidyl peptidase 4 that inactivates incretins such as GLP-1 and sitagliptin, agents that make the body more sensitive to insulin, thiazolidinedione, and agents that increase the excretion of glucose in the urine. When insulin is used in type 2 diabetes, a long-acting formulation is usually added initially, while continuing oral medications. Doses of insulin are then increased until glucose targets are reached. Blood pressure lowering. Cardiovascular disease is a serious complication associated with diabetes, and many international guidelines recommend blood pressure treatment targets that are lower than 140/90 mm of mercury for people with diabetes. However, there is only limited evidence regarding what the lower targets should be. A 2016 systematic review found potential harm to treating to targets lower than 140 mm of mercury, and a subsequent systematic review in 2019 found no evidence of additional benefit from blood pressure lowering to between 130 to 140 mm of mercury, although there was an increased risk of adverse events. 2015 American Diabetes Association recommendations are that people with diabetes and albuminuria should receive an inhibitor of the renin-angiotensin system to reduce the risks of progression to end-stage renal disease, cardiovascular events, and death. There is some evidence that angiotensin-converting enzyme inhibitors are superior to other inhibitors of the renin-angiotensin system such as angiotensin receptor blockers, or aliskiren in preventing cardiovascular disease. Although a more recent review found similar effects of angiotensin-converting enzyme inhibitors and angiotensin receptor blockers on major cardiovascular and renal outcomes. There is no evidence that combining angiotensin-converting enzyme inhibitors and angiotensin receptor blockers provides additional benefits. Aspirin. The use of aspirin to prevent cardiovascular disease and diabetes is controversial. Aspirin is recommended by some in people at high risk of cardiovascular disease, however, routine use of aspirin has not been found to improve outcomes in uncomplicated diabetes. 2015 American Diabetes Association recommendations for aspirin use are that low-dose aspirin use is reasonable in adults with diabetes who are at intermediate risk of cardiovascular disease. National guidelines for England and Wales by the National Institute for Health and Care Excellence recommend against the use of aspirin in people with type 1 or type 2 diabetes who do not have confirmed cardiovascular disease. Surgery and diabetes. Weight loss surgery in those with obesity and type 2 diabetes is often an effective measure. Many are able to maintain normal blood sugar levels with little or no medications following surgery, and long-term mortality is decreased. There is, however, a short-term mortality risk of less than 1% from the surgery. The body mass index cutoffs for when surgery is appropriate are not yet clear. It is recommended that this option be considered in those who are unable to get both their weight and blood sugar under control. A pancreas transplant is occasionally considered for people with type 1 diabetes who have severe complications of their disease, including end-stage kidney disease requiring kidney transplantation.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.